You know that feeling, right? You're staring at this huge pile of information, articles, notes, maybe some research papers, and you just feel overwhelmed. There's this knot in your stomach because you really want to get it, to understand a complex topic inside and out, like the pros do. But you don't want to drown in jargon or just skim the surface. You want those deep insights, those aha moments that stick with you. Well, that's exactly why we're here. Welcome to another deep dive. Today, our mission is to take a whole stack of source material. We've got bits from medical texts, scientific reviews, epi reports, and really distill it down, make it clear, make it fascinating, help you really master it. And today, we are diving deep, really deep, into shigellosis. This isn't just about listing symptoms. We're peeling back every single layer, looking at the nuances, the global impact, the huge efforts to fight it. By the end, you'll have that comprehensive grasp, like a seasoned infectious disease expert.
Exactly. We're going beyond just the what. We want to get into the why and the how of this disease. Why does it behave the way it does? How does it impact different people around the world so differently? And, what are the big challenges we still face? It's a really compelling story about a microbe's strategies and our efforts to push back. We'll cover everything in these sources.
Okay, let's dive in, starting right at the beginning. When we talk shigellosis, dysentery usually comes up. And the big breakthrough moment for understanding this came way back in 1897.
That's right, yeah. Thanks to Kiyoshi Shiga, a Japanese microbiologist. He was right in the middle of this massive, terrible dysentery epidemic, and he managed to isolate the actual bacterium causing it. He called it the Shiga bacillus, which we now know as Shigella dysentery type 1. A huge moment.
Okay, but there's a distinction here, isn't there, between Shigella bacteria and dysentery, the condition?
Absolutely crucial distinction. So while Shigella is maybe the most famous cause of dysentery itself is really a clinical syndrome. It's a set of symptoms. Clinically, you're looking for that triad: fever, really intense intestinal cramps, and then passing small, frequent stools that are visibly bloody and contain mucus, or pus mucopurulent is the term. So Shigella causes this really severe type of diarrhea, this syndrome, but other pathogens can cause dysentery too. It's more descriptive of the illness presentation.
Got it. That clarifies things. It's about the symptoms, not just the specific bug.
Yeah.
Okay, so let's zoom in on the bug itself then, Shigella. What makes it tick? What are its key features?
Well, fundamentally, it's a non-spore-forming gram-negative bacterium. Now, those terms, gram-negative especially, tell us about its cell wall structure, which affects how it interacts with us, our immune system, and even antibiotics. What's really fascinating, though, is how incredibly close it is genetically to E. coli. Like, DNA studies show they're almost the same species genetically. Yeah, but we consider Shigella separate mainly because its clinical behavior is so drastically different, and historically it was recognized as causing this specific severe disease.
So genetically almost twins, but one's often harmless and the other causes serious illness. How do labs actually tell them apart then, if the DNA is so similar? What are the key differences?
Great question. It comes down to some subtle but really consistent biochemical differences in motility. A big one is motility. Shigella is non-motile. It doesn't have flagella. It can't swim around like most E. coli can. That's a key giveaway. Also, biochemically, it typically doesn't produce gas when it ferments sugars. And it doesn't decarboxylate lysine or hydrolyze arginine. These are specific metabolic tests E. coli usually scores positive on. Now, there are a couple of tiny exceptions, like some rare types might produce indole or very occasionally use sodium acetate, but overall, these biochemical fingerprints are really reliable for differentiating them. It shows how sometimes small functional differences lead to huge differences in virulence.
Interesting. And I gather there are different types of Shigella too, serogroups.
Yes, exactly. We categorize them into 4 main serogroups, labeled A, B, C, and D, and each corresponds to a species. Serogroup A is Shigella dysenteria, that includes the type 1 Shiga discovered. Serogroup P is Shigella flachneri, which you see a lot in developing countries. Serogroup C is Shigella boydei, and serogroup D is Shigella sane, which tends to be more common in industrialized or emerging economies. They're differentiated partly by those biochemical tests, but also serologically by their surface antigens, which antibodies recognize. This typing is super important for tracking outbreaks and understanding global patterns.
It's still amazing how close they are to E. coli genetically, yet so different in impact.
Yep.
You touched on genomic insights. What has sequencing actually revealed about why Shigella is so pathogenic? What makes it cause such nasty disease?
Right. This is where you see Shigella's sort of evolutionary genius, if you can call it that. Why is it so virulent when it shares, like, 93% of its genes with harmless E. coli K12. Genome sequencing, comparing E. coli K12 and S. flexneri 2A, for example, points to 3 key genomic signatures that really define its pathogenicity. First, and this is crucial, it carries a large virulence plasmid, about 215 kilobases. This isn't just junk DNA, it's packed with genes specifically for causing disease. It carries most of the instructions needed for Shigella to be invasive, to actually get inside our cells. Take away that plasmid, and Shigella becomes much, much less harmful.
Okay, so a dedicated weapon package. What else?
Second, it's undergone significant genetic dilutions or alterations. This is fascinating. It's actually lost genes that would normally code for things like lysine decarboxylase that would reduce its pathogenicity.
So it became more dangerous by losing things.
Exactly. It's like it shed unnecessary baggage to become a more streamlined, efficient pathogen. It's a really striking example of reductive evolution for virulence.
That's counterintuitive, but makes sense. And the third signature.
The third, specifically for Shigella dysentery type 1, is the presence of genes encoding Shiga toxin. This isn't just any toxin, it's really potent cytotoxin. It directly kills our cells. This contributes massively to the severity of S. dysentery type 1 infections and sets the stage for dangerous complications like hemolytic-uremic syndrome, which we definitely need to talk more about later. These 3 things together make Shigella the formidable pathogen it is.
Okay, so we've got a handle on the bacterium itself down to its genetic tricks. Let's zoom out now. Where does Shigella hang out? How does it actually spread so effectively?
The main reservoir, really the only significant one, is the human intestinal tract. You might rarely find it in some higher primates, but for all practical purposes, humans are the source. And because huge numbers of bacteria are shed in the stool during the acute illness phase, the main transmission route is fecal-oral, especially through direct hand carriage. Someone doesn't wash their hands properly after using the toilet or changing a diaper, then touches food or surfaces. That's the classic pathway. But it's not the only way, unfortunately. Contaminated food or water can cause big outbreaks. In places with really poor sanitation, even flies can physically carry the bacteria from feces to food. And importantly, sexual transmission is also a documented route, especially in certain groups, so it has multiple ways to get around.
It sounds very adaptable in how it spreads. You also mentioned it has high infectivity. What does that translate to in the real world? How easy is it to catch?
Yeah, high infectivity is an understatement. It has an incredibly low infectious dose. Studies in human volunteers showed that swallowing as few as 10 to 100 bacteria can be enough to cause illness.
10. That's practically nothing.
Exactly. It's tiny. Think about what that means in crowded settings. In daycare center outbreaks, the attack rate, the percentage of exposed people who get sick, can be anywhere from 33% up to 73%. And among family members living with a sick child, about a quarter to a third might get secondary infections. This super low dose means even tiny lapses in hygiene can lead to transmission, making it incredibly hard to control, especially where sanitation is poor.
No wonder it's such a global problem. Can you give us the historical context? Where and when has Shigellosis hit hardest? Are there patterns?
Historically, big Shigella epidemics have always been linked to crowding and poor hygiene. Think soldiers in the field, people crammed into besieged cities, pilgrims on mass journeys, refugee camps. Those are the classic high-risk settings throughout history. Cyclically, places like the Indian subcontinent and sub-Saharan Africa have seen really devastating recurrent epidemics, often caused by that highly virulent S. dysentery type 1. These outbreaks often have very high attack rates and tragically high mortality. For instance, one study in Bangladesh during an S. dysentery type 1 epidemic found a 42% increase in the death rate among children aged 1 to 4. Just a massive impact on the most vulnerable.
That's devastating. So outside of those huge epidemics, is it just constantly simmering in some places? Is it endemic?
Very much so. Away from the big outbreaks, shigellosis is mostly an endemic disease, meaning it's always present in the population at some baseline level. And the vast majority, something like 99% of all cases worldwide, occur in the developing world. It's really concentrated in impoverished areas with poor hygiene and limited access to clean water. And we even see patterns in the types. S. flexneri tends to dominate in the least developed regions, while S. sane is more common as countries develop economically and in industrialized nations. It tells us something about how these different types adapt.
99% of the developing world. That's stark. What do the overall numbers look like? WHO estimates. What's the scale of the burden?
The scale is enormous. A major WHO review looking at data from 1966 to 1997 estimated around 165 million cases annually worldwide, and the brunt of that falls on young children.
Wow.
Yeah, 69% of those cases were in kids under 5. And the estimated annual deaths back then ranged anywhere from 5,000 up to possibly 1.1 million.
A million deaths. That's staggering.
It is. Now, there's maybe some hope that mortality rates have decreased a bit due to better nutrition and access to care in some places, but there's a huge counterproblem. The rise of multi-drug resistant, MDR Shigella, the widespread, often uncontrolled use of antibiotics has driven resistance like crazy. So even if supportive care improves, treatment is becoming much, much harder, potentially reversing some of the gains.
So it's a constantly evolving threat because of resistance. Where does it stand now compared to other diarrheal diseases, especially for kids?
It's still right up there at the top of the list of major threats. A really important study from 2013, a prospective case control study, looked at kids under 5 with moderate to severe diarrhea. Shigella was identified as one of the top 4 pathogens causing this severe illness globally. And even more telling, for children aged 12 to 59 months, it was ranked #1 as the cause of moderate to severe diarrhea. Those episodes specifically were linked to an 8.5-fold increase in mortality compared to average diarrhea mortality. The conclusion was clear. Shigella has to remain a top priority for health programs worldwide.
Beyond the immediate sickness and death, you mentioned a nutritional impact. That sounds like a hidden long-term consequence. Can you elaborate?
Yes, and this is so important, but often overlooked. Shigellosis frequently messes up a child's nutritional status, both short-term and long-term, especially in endemic areas. It's a double whammy. The kids get severe anorexia, they lose their appetite, feel sick, can't eat, plus they suffer from exudative enteropathy.
Exudative enteropathy.
Yeah, it basically means the gut lining is so damaged and inflamed from the bacterial invasion that it's leaking protein and other nutrients into the gut lumen, which are then lost in the stool. So they're taking in less nutrition and losing more. This combination rapidly worsens their nutritional state. And chronically, this is now recognized as a major contributor to stunted growth in children in developing countries. It has lifelong consequences for physical and cognitive development.
A truly vicious cycle.
Yeah.
What about age? Does endemic shigellosis affect certain age groups more?
Definitely. There's a clear peak in the pediatric population, especially young children under 5. Their immune systems are still developing, and they often have higher exposure rates, maybe in daycare or just playing. Then, interestingly, it becomes relatively rare in young and middle-aged adults in endemic areas. They've likely acquired some immunity from childhood exposures,
Right.
but then the incidence tends to creep up again in the elderly. Their immunity might be waning, they might have other health problems, or they might be in care facilities where transmission can occur more easily. So it hits the very young and the very old hardest.
And what's the picture in the industrialized world? Is it completely different, or does it still pop up?
It's definitely a different scale. It's not endemic in the same way, but Shigella absolutely still causes problems. You see localized outbreaks, usually in kids, often linked to inadequate hygiene in places like daycare centers or institutions. Beyond those settings, a lot of cases are travel-related. People pick it up while traveling in endemic regions and bring it back. It's a common cause of pretty severe traveler's diarrhea. And occasionally you do get rare foodborne or waterborne outbreaks, but they tend to be more isolated incidents compared to the constant pressure in developing countries.
So even with good sanitation, its high infectivity means it can still find ways to spread. It reminds me of what we discussed about non-typhoidal salmonella, NTS. Even with efforts to clean up the food supply, NTS rates haven't dropped as much as other foodborne bugs in places like the U.S. Does that suggest a similar kind of complex epidemiology for Shigella?
I think that's a really apt comparison. The struggles with controlling NTS, despite all the food safety measures, really highlight that these enteric pathogens often have complex transmission routes. It's not just about contaminated food from one source. You've got person-to-person spread, potential environmental reservoirs, maybe asymptomatic carriers.
Yeah.
It all adds up, making them really tough to eliminate. It absolutely reinforces that for Shigella with its incredibly low infectious dose, easy fecal-oral spread, travel links, and potential food-water routes. You need to understand that whole complex web to find effective control points. It's definitely not a simple fix.
Okay, let's shift focus now and go right inside the body to the battleground itself. How does Shigella actually launch its attack at the cellular level? What's the invasion strategy?
Right, so it starts with oral contamination, usually that fecal-oral route. And interestingly, Shigella isn't actually super hardy in the environment. It doesn't survive outside the body for long periods, which makes its efficiency even more remarkable. A key factor Enabling its low infectious dose is its ability to withstand the very low pH of the stomach. It's resistant to stomach acid. This allows it to pass through that major chemical barrier mostly unharmed and reach the intestines ready to invade. Many other bacteria would just be killed off by the stomach acid.
Okay, so it survives the stomach. Once it's in the intestines, does it immediately cause that bloody diarrhea, the dysentery?
Not usually right away. The illness often unfolds in phases. There's typically an initial phase of watery diarrhea. This comes before the dysenteric phase. This early watery diarrhea is thought to happen because of active secretion of fluid and electrolytes into the gut, plus problems with water reabsorption, especially in the jejunum, part of the small intestine. We've seen this clearly in monkey studies. It's likely caused by a combination of an enterotoxin the bacteria produces, called Shigellosis, and the early inflammation it starts causing. Then, after this initial watery phase, maybe hours, maybe a couple of days later, the classic dysenteric syndrome kicks in. That's when you see the bloody mucopurulent stools, which directly reflect the bacteria physically invading and damaging the lining of the colon.
This is where that virulence plasmid we talked about comes into play, right? How does Shigella use it to actually get inside our cells and cause all this damage? This sounds like the really sophisticated part of its attack.
Absolutely. This is the core of its invasive strategy. That virulence plasmid, around 214 kilobases, is loaded with about 100 genes, and about 25 of those genes code for a remarkable piece of bacterial machinery called a type 3 secretion system, or
A
TTSS.
molecular syringe, I think you call it.
Exactly. Think of it like a nanoscale syringe or needle. The bacteria uses it to physically puncture the membrane of our host intestinal cells. This creates a direct channel, allowing the bacterium to inject its own specialized proteins called effector proteins, things like IPAB, IPAC, IPA, straight from its own cytoplasm into ours. It bypasses our cells' outer defenses completely.
Wow. So it's not just knocking on the door, it's injecting its own agents directly inside. That's sneaky.
Incredibly sneaky, and it uses these injected proteins to basically trick our intestinal epithelial cells into taking it up. It induces its own engulfment. This can happen right at the openings of the colonic crypts, these little pockets in the colon lining, or sometimes it uses specialized cells called M cells as a gateway. M cells normally sample things from the gut for the immune system, but Shigella exploits them to get across the epithelial barrier.
Okay, so it gets across the barrier.
Yep.
Then what? Does it just start multiplying?
Well, first, it deals with the local security guards. Once it crosses, it quickly induces apoptosis, or programmed cell death, in the macrophages residing just underneath the epithelium. These are immune cells that should engulf and destroy invaders. The IPAT effector protein plays a big role here. It activates something called caspase-1, which leads to the release of potent inflammatory signals like IL-1 and IL-18, and also activates NFP, which ramps up inflammation. So it kills off the first responders and triggers inflammation simultaneously.
A multi-pronged attack right from the start.
Precisely. Then, once it's actually inside the main intestinal epithelial cells, those injected effectors manipulate the cell's internal scaffolding, the cytoskeleton. They trigger rearrangements that cause the host cell to actively pull the bacterium inside. The bacterium initially ends up in a little membrane bubble, a vacuole. But it doesn't stay there long. It quickly lyses or breaks open that vacuole and escapes directly into the host cell's cytoplasm, the main internal fluid compartment. Now it's free inside our cell.
That's terrifyingly efficient. It gets in, kills immune cells, forces its own uptake, then breaks out of its little prison inside our cell. How does it spread from there and cause the widespread damage we see in dysentery?
This is another really clever part of its strategy. To spread to adjacent cells, it doesn't even need to go back outside. It stays intracellular. It uses host cell actin, part of the cytoskeleton, to build a kind of comet tail behind it. This actin tail propels the bacterium through the cytoplasm with surprising force, eventually pushing it directly into the neighboring epithelial cell. This cell-to-cell spread is incredibly efficient because the bacteria remain hidden from antibodies and other immune defenses out in the gut lumen. They just keep invading cell after cell from within.
Like a stealth invasion moving through the tissue.
Exactly. And as more and more cells get infected, they release floods of inflammatory cytokines, IL-8, IL-1, IL-18. These act like alarm bells, recruiting huge numbers of immune cells, especially neutrophils, PMNs, to the site. This massive influx of PMNs, combined with the direct damage from the bacteria multiplying and spreading, completely destabilizes the epithelial barrier. It causes intense inflammation, tissue damage, ulceration. That's the acute colitis characteristic of shigellosis. And here's a final twist. Some of those injected TTSS effectors can actually subtly modulate the host inflammatory response. They don't completely shut it down, but they might dampen certain aspects, paradoxically helping the bacteria survive longer within that inflamed environment. It's a very sophisticated manipulation of our own
An
defenses.
incredible level of manipulation. Now, you also flagged the Shiga toxin, especially from S. dysentery type 1, as being particularly important for severity. How does that toxin work? And how does it cause problems beyond just the gut?
Shiga toxin is a classic example of an AB toxin. It has two parts. The B subunit, there are actually 5 of them, acts like a key. It specifically binds to a receptor molecule called globotriosylceramide, GB3, found on the surface of certain host cells. These GB3 receptors are present on cells lining blood vessels, and importantly, they're abundant in the kidney. Once the B subunit binds, the A subunit, which is the actual toxic part, gets taken inside the cell through endocytosis. Inside the cell, the A subunit gets activated and does its damage. It acts as an enzyme that specifically targets the 28S ribosomal RNA.
Ribosomal RNA, that's part of the ribosome, the cell's protein-making machinery.
Exactly. By chemically modifying the 28S rRNA, the Shiga toxin effectively jams the ribosome. It prevents it from reading the genetic code and synthesizing new proteins. This causes a complete shutdown of protein production in the cell. Without the ability to make proteins, the cell quickly dies. And the danger becomes systemic because this toxin, produced in the gut, can cross the damaged intestinal barrier, get into the bloodstream, and travel to other organs. It then binds to those GB3 receptors, particularly on the endothelial cells lining tiny blood vessels in the kidney. This damage in the kidneys is what leads to the devastating complication known as hemolytic-uremic syndrome, HUS.
Okay, that explains the mechanism. Let's shift to what the patient actually experiences. How does shigellosis typically present? Does it always look the same?
No, the clinical picture can vary quite a bit. The specific infecting serotype matters somewhat, but factors like the patient's age, immune status, and nutritional status are actually much more important in determining severity. That's why you see such a strong link between poverty, poor hygiene, and more severe disease, especially in young children under 5. A malnourished child is going to have a much rougher time with Shigella. Generally, though, the illness tends to follow a pattern, often described in 4 phases. First is the incubation period, the time between exposure and symptoms, usually 1 to 4 days, maybe up to 8. Second comes the watery diarrhea phase. This is often how it starts, before the classic dysentery. The patient might have a fever, feel generally unwell, malaise, lose their appetite, anorexia, have abdominal cramps ranging from mild to severe, maybe vomiting, and tenesmus, that feeling of needing to poo but not being able to. In kids, this phase can be more dramatic, with high fevers, maybe 40, 41 degrees C, 104, 105 days of fuse. And interestingly, especially in developed countries, this watery diarrhea might be the only phase. The illness might stop there, making it harder to recognize as shigellosis initially.
Okay, but often it progresses.
Often, yes. Within hours or days, it moves into the 3rd phase, dysentery. This is the hallmark stage. You get the frequent passage of small amounts of stool that are visibly bloody and contain mucus or pus. Tenesmus usually gets worse. Abdominal cramps intensify. This reflects the bacteria actively invading the colon, causing acute colitis, mostly in the lower part, the distal colon and rectum.
This is the stage people typically think of with dysentery. Now, is dehydration a major worry here, like with cholera?
That's a really key point. Unlike cholera or other watery diarrheas that cause massive fluid loss, Shigella dysentery typically does not cause severe dehydration. The main damage is inflammation and ulceration in the colon, leading to blood and mucus loss, not huge volumes of water loss from the small intestine. So if someone presents with classic dysentery and severe dehydration, you'd start thinking about other possibilities, or maybe a co-infection. It's not the usual picture for shigellosis alone. If you were to do an endoscopy at this stage, you'd see a very inflamed, swollen, edematous colon lining, sometimes with patches of whitish yellow material called pseudomembranes, basically layers of dead cells, fibrin, and inflammatory cells. The good news, though, is that most episodes are self-limiting. Even without treatment, they often resolve within about a week. With the right antibiotics, recovery is usually much faster, within days to a week, typically with no lasting gut damage. And then there's a potential 4th phase, the post-infectious phase, which can involve complications like reactive arthritis cropping up later.
Okay, so many recover well, but you mentioned acute life-threatening complications. Who's most at risk, and what are these really dangerous turns the illness can take?
Right. The severe, life-threatening stuff is seen most often in the vulnerable groups. Kids under 5, especially if malnourished, and the elderly. Certain clinical signs suggest a higher risk of death in severe cases. These include having non-bloody diarrhea, which might paradoxically indicate a different or overwhelming process, moderate to severe dehydration. When it does occur, it's serious, bacteria in the bloodstream, bacteremia. Oddly, the absence of fever in a very sick patient, severe abdominal tenderness, and rectal prolapse. The major complications fall into two camps: intestinal and metabolic. Intestinal ones include toxic megacolon, which we need to discuss more, intestinal perforation, a hole in the bowel wall, and rectal prolapse. Metabolic issues can include low blood sugar, hypoglycemia, low sodium, hyponatremia, and sometimes dehydration.
You said bacteremia is rare. The infection usually stays in the gut. And what about effects on the brain, especially in kids? That sounds scary.
Yeah. Bacteremia Shigella, getting into the blood, happens in less than 5% of cases. When it does, it's usually in the severely malnourished or HIV-infected patients, suggesting their weakened defenses allow it to escape the gut. Neurological problems are definitely a big concern, particularly in kids under 5. They can range from just altered consciousness, lethargy, confusion, all the way to seizures, delirium, or even coma. And sadly, these are associated with a worse prognosis. It's important to differentiate, though. Often, the altered mental state is driven more by the very high fever or severe metabolic problems like hypoglycemia or electrolyte imbalances, rather than Shigella directly infecting the brain, meningitis, or causing that rare historical Ikiri syndrome.
Ikiri syndrome, what was that?
It was this severe toxic encephalopathy, described mainly in Japanese children with shigellosis decades ago, characterized by weird posturing, brain swelling, fatty changes in organs. But today, we think most neurological symptoms in shigellosis are secondary to the fever and metabolic chaos. And then there are really rare things like Shigella causing pneumonia, vaginitis, or eye infections, keratoconjunctivitis. And one fascinating modern insight: if you see really severe, unusual things like meningitis in someone who isn't severely malnourished, it might signal an underlying genetic defect in their innate immunity, like an IR4 deficiency. That requires looking beyond the bug to the host's specific vulnerability.
Okay, among all those complications, you specifically flagged two as critical: toxic megacolon and HUS. Let's break those down. They sound really serious.
They absolutely are. Toxic megacolon is a direct result of the intense inflammation spreading deep into the muscle layer of the colon wall. This paralyzes the muscle, causing the colon to dilate massively and dangerously. Clinically, the patient develops a very distended, tender abdomen, maybe with signs of peritonitis if it's really bad. An abdominal x-ray is key here. You see this huge dilation, especially of the transverse colon. You might see thumbprinting from the swollen lining, loss of the normal folds, haustra, maybe pseudopolyps, air in the bowel wall, pneumatosis coli, or free air under the diaphragm, pneumoperitoneum, if it perforates, are really bad signs. We also have to watch out for things that worsen it, like low potassium or using drugs that slow the gut.
A very dangerous situation. And HUS, hemolytic-uremic syndrome, linked to the Shiga toxin.
Yes, HES is tightly linked to Shiga toxin, especially from S. dysentery type 1 in developing countries. In places like the U.S., Shiga toxin-producing E. coli or EHEC is a more common cause of HUS, but the mechanism is similar. It usually pops up a few days into the diarrheal illness. The signs are pallor, paleness, extreme weakness, asthenia, irritability, sometimes bleeding from the nose or gums, decreased urine output, oliguria, and swelling edema as the kidneys fail. HUS is defined by a critical diagnostic triad. First, microangiopathic hemolytic anemia. Red blood cells get shredded as they pass through tiny clots in small blood vessels, so you see anemia, low hemoglobin, often ADGO, fragmented red cells called schistocytes on the blood smear, high LDH, high free hemoglobin, and the body trying to compensate with lots of new red cells, reticulocytes. It's Coombs negative, meaning it's not an autoimmune attack on red cells. Second, thrombocytopenia. Low platelet count, usually 50,000 a year because platelets are being used up forming those microclots. And third, acute renal failure. Those microclots damage the filtering units, glomeruli, in the kidneys, causing creatinine levels to shoot up. Thankfully, kidney function does recover in a majority of cases, maybe up to 70%, but not always completely. Sometimes you also see extremely high white blood cell counts called leukemoid reactions along with HUS.
That triad is terrifying. Red cells destroyed, platelets consumed, kidneys failing. And briefly, you mentioned reactive arthritis as a later complication.
Right, that's a post-infectious, immune-mediated thing. It can show up weeks or months after the initial Shigella infection is gone. It's strongly associated with people who have the HLA-B27 genetic marker. And here's a really specific point. It seems to occur only after infection with Shigella flexneri, not the other types. About 3% of people infected with S. flexneri might develop it. Symptoms are typically arthritis, often in large joints, eye inflammation, conjunctivitis or uveitis, and urethritis. It can linger for months or years and sometimes become a chronic, hard-to-treat arthritis.
Okay, with all these possible symptoms and complications, how do doctors actually nail down a diagnosis of shigellosis? How do they sort it out from everything else it could be?
Yeah, the differential diagnosis really depends on where you are in the patient's situation. In developing countries, you have to think broadly about other bacteria that cause invasive diarrhea. Salmonella, Campylobacter, C. diff, Yersinia, and crucially, the parasite Entamoeba histolytica, which causes amoebic dysentery, is a major consideration. You absolutely need lab tests, stool exams for bacteria and parasites to tell these apart definitively. In industrialized countries, the list is a bit different. You'd still consider those other bacteria, especially Campylobacter or Salmonella, maybe C. diff if there's antibiotic history. But you also have to strongly consider a first presentation of inflammatory bowel disease, IBD, like Crohn's or ulcerative colitis, because the symptoms of acute colitis can look very similar. Here, the patient's history is key. Recent travel to an endemic area. Exposure in a daycare, that points more towards shigellosis, no travel history, maybe IBD is more likely. But again, you need tests.
So, history first, then lab tests. What can they see just by looking at the stool under a microscope initially?
A simple microscopic stool exam can give quick clues. For Entamoeba histolytica, you might see the amoeba trophozoites themselves, sometimes containing ingested red blood cells. That's pretty specific. And usually there are relatively few inflammatory white blood cells, PMNs. In contrast, bacterial invasive infections, especially Shigellosis, typically show tons of PMNs under the microscope, sheets of white blood cells reflecting that intense gut inflammation. But the caveat is Shigellosis can start as just watery diarrhea, which might not show all those PMNs, so you can't rely solely on the microscope. You always need to try and culture the bacteria for a definitive diagnosis.
Right, so the gold standard is actually growing the bug. How is that done, and what are the challenges, especially if the bacteria are fragile?
Exactly. The gold standard is isolating and identifying Shigella from a stool sample. But yeah, there are challenges. Shigella is notoriously delicate. It doesn't like changes in temperature or pH, so it can easily die off during transport from the patient to the lab, especially if there are delays or improper handling. This leads to false negatives. To combat this, special transport media like buffered glycerol saline or Carey-Blair medium are used. They help keep the bacteria alive longer. But even then, getting the sample onto the actual culture plate in the lab as quickly as possible is crucial. For sampling, the best bet is to get a bit of the actual bloody or mucoid part of the stool. That's where the bacteria are most concentrated. Rectal swabs taken during the acute phase also have a pretty high success rate. Blood cultures are rarely positive, less than 5%, but worth doing if the patient seems septic.
So, sample arrives at the lab, hopefully intact. What media do they use to grow it? How do they pick out Shigella?
Labs usually use a combination of media to maximize the chances. They'll often use a non-selective medium first where lots of things can grow. Then, low-selectivity media like McConkey agar. These inhibit some irrelevant bacteria and highlight Shigella because it doesn't ferment lactose. The colonies stay clear or pale, unlike E. coli, which turns pink red. Then they use high-selectivity media like hectoin, HEA, Salmonella Shigella, SS agar, or XLD agar. These are designed to really suppress the growth of normal gut flora and make Shigella and Salmonella colonies stand out, often as clear or greenish colonies, typically without the black centers that indicate H2S production, which Shigella doesn't do. After incubation overnight, they look for those characteristic small, translucent, non-lactose fermenting colonies.
And once they have suspicious colonies, how do they confirm it's actually Shigella and maybe which type?
They'll pick those suspicious colonies and run biochemical tests. Standard panels check for those key features. Ferments glucose, usually without gas, doesn't ferment lactose, doesn't produce H2S, and is non-modal. That gives a presumptive ID. For definitive confirmation and typing, they move to serology. They use specific antibodies, antisera, that react with antigens on the bacterial surface. They'll usually start with group-specific antisera to determine if it's group A, dysentery, B, flexneri, C, boydii, or D, sonnei. These are widely available. Getting down to the specific type within each group, like S. flexneri 2A versus 1B, requires type-specific antisera. These are much less common, more expensive, and often only available in reference labs because there are so many different types. So full serotyping can be complex and often requires specialized labs.
Okay, so they've identified Shigella. Now, how do we fight back? Antibiotics seem critical, but you mentioned resistance is a huge issue.
Absolutely critical. Because it's an invasive disease, antibiotics are necessary. But yes, the story of Shigella treatment since the 1960s is largely the story of escalating multi-drug resistance, MDR. It's the dominant factor now. Resistance patterns vary hugely by region, making treatment choices tricky. This resistance spreads in two main ways. Specific resistant strains spread globally, clonal spread, and resistance genes jump between bacteria on mobile bits of DNA, like plasmids and transposons, horizontal transfer. As a result, many of the old standard antibiotics, ampicillin, trimethoprim sulfamethoxazole, TMP-SMX, tetracycline, chloramphenicol, are now largely useless against Shigella in many parts of the world.
What about the fluoroquinolones, like Cipro? Weren't they the big guns for a while? How are they holding up?
They were the big guns, but resistance has caught up rapidly there too, which is really worrying. It's mostly due to mutations in the bacterial genes for DNA gyrase and topoisomerase Phe, the enzymes these drugs target. You can see the timeline clearly. In the late 80s in India, drugs like ciprofloxacin were lifesavers, highly effective even against MDR-S dysentery type 1. But just a few years later, outbreaks in India and Bangladesh were already showing 5% resistance to these same drugs. And fast forward to the U.S. data from 2014-2015 showed fluoroquinolone resistance in Shigella isolates hit 87%.
87%. That essentially makes them unusable empirically in many cases.
Pretty much. It means you really need susceptibility testing, which isn't always available quickly. The implications are huge. It underscores the urgent need for rational antibiotic use. Every time we use an antibiotic, we create pressure for resistance to emerge. It's also worth noting we often lack good data on resistance in community-acquired strains as opposed to the ones that make it to reference labs. And this isn't just a Shigella problem. It's the same story with MDR salmonella and other enteric pathogens. It's a global crisis requiring action across human medicine, animal agriculture, everywhere.
Given this resistance nightmare, what are the current treatment recommendations? What are the benefits? And what drugs are still considered viable options?
Well, the benefits of effective antibiotic treatment are still significant. Faster clinical improvement, usually within 48 hours, lower risk of complications and death, shorter duration of illness, and quicker clearing of bacteria from the stool, which reduces transmission. That last point is why U.S. guidelines recommend treating every confirmed case to limit spread. Despite resistance, fluoroquinolones, like ciprofloxacin, are often still listed as first line if the local strains are known to be susceptible or if testing confirms it. The dose is typically 500 milligrams twice daily for adults for 3 days, longer for S. dysentery or immunocompromised patients. Pediatric dosing needs care, considering factors like drug half-life.
And if fluoroquinolones are out due to resistance, what are the alternatives?
Second-line options include certain cephalosporins or beta-lactams. Pivmecillinum is an oral option, but it has drawbacks. Cost: no pediatric form, needs frequent dosing 4 times a day for 5 days, and resistance is emerging. Ceftriaxone, given by injection, usually IM, is another choice, especially for severe cases or hospitalized patients, typically 2 to 5 days. But its efficacy isn't fully validated in all contexts, and injection isn't ideal outpatient. Azithromycin, an oral macrolide, is also used, often as a single high dose or a short course, 1 to 5 days. But again, concerns exist about cost, validated efficacy, borderline drug concentrations, and the potential for rapid resistance emergence that can spread to other bacteria. The choices are getting tougher.
Yeah, the duration of treatment. You mentioned it varies.
Yes, it's tailored. For uncomplicated infections with S. flexneri, suni, or boydii in healthy people, a 3-day course is usually enough. For the more dangerous S. dysentery type 1, a 5-day course is recommended. And for anyone immunocompromised, treatment is typically extended to 7-10 days. We always have to remember the vulnerability of young children, who make up most cases. While quinolone use in kids requires caution, shigellosis is a recognized indication when necessary based on resistance patterns. It's a constant balancing act.
Beyond the antibiotics, what about supportive care? Is aggressive IV rehydration needed? How crucial is nutrition?
Good question. Unlike cholera, severe dehydration isn't the main feature of shigellosis, so aggressive 5E fluids are less commonly needed, especially in well-nourished populations. However, in developing countries, malnutrition itself is a huge risk factor for death from diarrhea. So, focusing on nutrition is absolutely vital. If rehydration is needed, oral rehydration solution, ORS, is the way to go, unless the patient is unconscious or in shock. The standard 1SF reduced osmolarity ORA is key. Its specific composition is optimized for gut absorption and is much more effective than plain water or sugary drinks for non-cholera diarrhea. Even if Shigella affects gut transport mechanisms somewhat, ORS is still the best approach for oral rehydration. And critically, nutrition should be reintroduced early. Don't withhold food. Early refeeding is safe, helps the gut heal, combats malnutrition, and improves outcomes. Keep breastfeeding infants. Nutrition is just as important as antibiotics in these settings.
That makes sense. Are there any common symptom relief treatments that should actually be avoided with shigellosis, things that could make it worse?
Yes, definitely. This is a major warning. Avoid antimotility agents, drugs like loperamide that slow down the gut. They've been linked to prolonged fever in studies, and there's concern they might increase the risk of toxic megacolon by keeping the toxins and bacteria in contact with the bowel wall longer. They've also been associated with HUS in kids with EKG infections. So for safety, the strong recommendation is do not use antimotility drugs for bloody diarrhea. The risks outweigh any potential benefit.
Good to know. Okay, what about treating those specific severe complications if they happen? Toxic megacolon, perforation.
For toxic megacolon, there's no single perfect approach. It needs close monitoring by medical and surgical teams. You have to aggressively correct dehydration, electrolytes, especially low potassium, and anemia. Nasogastric suction can help decompress the bowel. Parenteral nutrition isn't proven helpful. If the colon stays massively dilated after 48-72 hours despite medical management, surgery, colectomy, is often recommended to prevent perforation, though some might wait longer if the patient is clinically improving without perforation. Intestinal perforation is an absolute surgical emergency requiring immediate surgery and intensive care support.
Down rectal prolapse.
That needs prompt, gentle manual reduction. Using a gloved hand or warm wet cloth with the patient in a knee-chest position, you carefully push the prolapse tissue back in. If it's very swollen, applying gauze soaked in warm magnesium sulfate solution can help reduce the swelling first. It might recur during the illness, but usually resolves once the dysentery gets better.
And finally, HUS. What's the treatment there?
HUS management focuses on supporting the failing kidneys. Strict fluid restriction is key to prevent overload. You stop ORS and potassium-rich foods. In severe cases with significant kidney failure, hemofiltration or dialysis is often needed to clean the blood until the kidneys can hopefully recover.
So we've covered diagnosis and treatment in detail. What about stopping it from spreading in the first place? Prevention and control.
The absolute cornerstone is hygiene. Rigorous hand washing with soap and water after using the toilet, after changing diapers, before preparing or eating food is the single most effective measure. In outbreak situations, like in hospitals or institutions, additional measures are needed. Disinfecting stool, example with hypochlorite solutions, and strict environmental cleaning protocols. Ideally, patients should have negative stool cultures before being considered non-infectious. If these measures are followed, recurrences are usually rare.
Looking ahead, with antibiotics facing such challenges, what's the future hold? Are vaccines or better diagnostics on the horizon?
That's the multi-million-dollar question. Despite the desperate need, there is currently no licensed Shigella vaccine available. Development has been tough. One major hurdle, especially for S. flexneri vaccines, has been the lack of good animal models that accurately mimic human disease, making it hard to test candidate vaccines effectively. But there is progress. Some newer vaccine candidates are showing promising immune responses and protection in preclinical studies, like in mice. This gives hope for moving towards human trials. The need is incredibly urgent, especially with antibiotic resistance spiraling. We desperately need preventative tools, and this mirrors the broader need in controlling enteric diseases. We also urgently need better vaccines and rapid point-of-care diagnostics for pathogens like NTS, especially in developing countries. Advances in Shigella control are part of this larger push for better tools against major gut pathogens.
Wow, this has been an incredibly thorough deep dive. We've really gone from Kyoshi Shige's discovery all the way to the latest genomic insights, the complex battle inside the body, the global impact, and this huge challenge of antibiotic resistance. And for you listening, really grasping these details, these nuances, it gives you that edge. You're moving beyond just facts to a much deeper expert level understanding of what makes Shigella tick and why it's such a persistent global health problem.
Absolutely. It really highlights the incredible adaptability of these microbes and the constant effort needed from science and public health just to keep pace.
So as we wrap up, here's a final thought to chew on. Given Shigella's amazing ability to adapt, its low infectious dose, and this relentless rise of antibiotic resistance, what kind of truly unexpected innovation, maybe something beyond just a new vaccine or drug class, do you think have fundamentally changed the game? What novel approach might really tip the scales in our favor against resilient pathogens like this? Something to think about. Keep digging, keep questioning, keep learning. Until next time on The Deep Dive, stay curious.